enter in the questions you want to ask. So, and if you have questions tomorrow, any question you enter the should put that function in there. If you also for your low efficiency mute, we every microphones muted during the presentation until time that's so the session topic is best presentation right, and I mentioned this more and record anything on our website. They were the session, he was in South Africa, and it was currently working with family medicine residency. So,
really expert raise the problem but I think the reason I will be talking about not that that is the one of my so if for the patients program in the problems the basic education program to giving feedback to practitioners. So I think that the concept of intelligence program and the disciplinary group I said and to have various so that role I do privilege to offer visitors what we use is a management assessment, but also the portion that we is audit. The total number of charts and conditions. Then we have a rubric that we use to go through those charts and the certain criteria. I can say that every year I've started to notice things in one of the efficiencies many positions have capacity documentation. And one things I like to see sometimes doing some of the same. I think the same report you may have to present to me talk with some of the things that you see and some other research you see with today's talk you have specific on the EMR on it, and I will talk about some of the medium. I think a good way to start is to make some basic stuff. So from what we said, maybe thing to talk is to recognize the legal aspects, make to do it for and there are some information. I talk a little bit about the on the state that we have to also think it continue investigation. Some of all a few slides just the different aspects of that file. And if you want to provide a side reading, go read the file CPA's website. To this environment, and some of these are general, but in general, everyone should have the ground information. That's very different than a patient had be on the report. As there has to be some kind around how the visit and more about it. There has to be taken into action. In the there nothing is not after that what decision whether there are investigations or follow-up something like that. I have to just start off with one of the areas that we see in documentation as the rule is this right what's expected. Other requirements is that the report patients or not it be in English, and you might start as well. I've had the opportunity to visit all to keep their records in their own language, and they use anyone but itself. And it has been personally and I'm evidence times I tell you that we use zero and that your interaction the most one is if someone has to deal with that same patient having up all the next day as a follow-up, it's important to know that we tend to get things pretty quick, especially if you see many patients as to next. Well, I have to try to catch up, well, that so that's sort of the risk that you're talking about. I say 6 annual, which is very number of hours. Sort of the go-to for. I do see and I do not have the current number, but I don't think it's more than 87% opposition. And yes, sure that you can watch or even show your patients, and we often share our monitor with our patients so they see exactly what we type and where we are in the record. Must be an easy method to access the record. So in the clinic, you must have access to it. If you work from home, you can access the record. Record if there is a request for of the record or transfer of the issue. Records must be printed in chronological order, so usually related to the it must be chronological order. It must be a article in the EMR, so if you change a label, the record set at a time. So and then it's kind of interesting it's my kept 6 years, so probably come back to 5K, but it's actually my life that we must 6 years after the last even after you saw the patient after the last consultation must proceed. 4 years time age of journey, make sure it's 18. We have the last so 6 years in years now I looked at the reason was the so records and the majority of the passwords and it's so to continue. When you decide to hire or start to change your practice, you can be right to the doctor's practice. You can transfer your medical records to the department. This is usually expected to have a position. And you also have to ensure security for each office, especially not practice. I don't remember the the records on a medical website. You also have additional from not go to it, but all the legal it's a little so when um if everything and and maybe so every approach of human profile. So you call it a profile. Is the same knowledge, but that's the summary of the patient. I look at EMR, I know just sort of column on that's all. And the profile needed with the patient diabetes plus we'll social information, so married, children, employment, that sort of thing, and then immunization. So these are things that in the patient approach. And again, the next thing that I would like to experience often have to I sometimes don't use it at all. And this is information is part of the report you have the Mars as like that you have today. What is the rate or second? So yours, your decision itself, and if you are using organization management or doing programs, then it requires that you push it to use for patient and say, you a copy of you your you know you could frequently need assistance. Sometimes it's a copy ask. That's why it's also important to copy for legal purposes. Other health providers or speech pathology portals make a document and then deployment. But that I for the agents letter because there is in the C is quite good. And also there are from college these are the ones that often most of the people know this that but we see that is not correct to so also different components just with the scan part. So everything that gather from the your the information we get distribution off it may borrow your system that to remember the that the and information you think about all the patients we often ask about important to the next check yourself will gather in the since we will document is not silent from someone else. Also, use a question of being it is good to have some kind of check this one is the like so important to ask you about or also be a patient at that in this might really help actual results. Also, the progress, like I say, poorly controlled diabetes or well controlled hypertension is typically what I would put in the assessment part. The plan is usually your management. So often we have pharmacy planning. Also, we document you prescription if you recommend counseling for patients. You are investigation patient or other things for patient here. your mind to things like bladder valve or something like that. So the community that you want to help us. And then just to have some position asking and how to go maybe return to the research to improve within good supported time there. So a little about that as well. If you're something like that. It's a very good procedure and we have to session. Also, having family doctors to do procedures, it's important to have procedure. So if the procedure time is important. It's important to name the procedure. It's bilateral important to was the procedure. The surgeon said anesthesiologist. I will also document their procedure that was present or itself, obviously, if you if you're leaving anything behind, and the reason for that is the person on the other end receiving it will have to triage how soon they need to see this patient, and so the more information they have, the better. And then definitely relevant medical information or a chart summary. And that's, if I can go back to the cumulative patient profile, that's where it's very handy if you have an updated cumulative patient profile, because it's very easy to then just print a copy of that and attach it to the referral letter instead of having to dictate or type everything into the letter. So one of my keys for having a good cumulative patient profile is it makes your life easier when you're dealing with stuff like this. I can tell you it really concerns me when I'm doing an assessment in a physician's office and I see a referral letter, please do colonoscopy. And that's it, nothing else. And I can just imagine the person on the other end receiving that referral letter wondering, okay, why and how soon, how urgent, and that sort of thing. So it is important to put a little bit of information in there. So I want to talk a little bit about templates, because in the EMR, that's one of the nice things that we have is a template or a cookie cutter. And so if you're doing a lot of a certain thing, there's no fault in creating a template for that. I mean, I do vasectomies and I have a template for my procedure note for the vasectomy. And you've probably seen many specialists in their different fields having templates for an eye exam or a prostate exam or whatever the case is. So I think templates are very good. And one of the reasons why they are good is it's good for time efficiency. You don't have to retype everything that you do every time. It definitely saves time. It also makes sure that if you have a really good note for a certain procedure, then you do want to replicate that good practice. The other thing, it's also a good reminder of things that you need to perform or things that you need to document. So if I'm using a template for a periodic health exam, it has checkboxes that I have to remember. I need to talk about family history. I need to talk about immunizations or stuff like that, or advanced care directive. So it's a good reminder of what to do. And then at the end, it's good to document all those things that you've done. And I'll come back later on with some of the maybe not so good things about templates, but I'll leave that for later. So last part of this talk is to talk a little bit about common errors that we see. And I'll start with the cumulative patient profile. And I've already highlighted some of the issues, but the biggest issue is that if you don't have a summary of your patient, especially if you're seeing a lot of patients or you're new in your clinic and you don't know them very well yet, it is very handy to have a quick glance at the patient profile to remind you of things that they have. And even the patients that you've had for 10 years or more, it's sometimes good to just glance at your profile, because sometimes you forgot that they had a certain procedure or a certain issue in their life after a few years, and it's good to come back to those sometimes. It's also very important for someone else to, if they need to follow your patient or see your patient. So if you're working in a group practice or in a walk-in clinic, it's very important to have a profile so that if a new doctor comes to see the patient, they can spend 10 seconds quickly to get a picture of the patient instead of having to look at the last 3 or 4 visit notes to try and form a picture. The other thing is if you are doing a Framingham risk score or some other kind of risk score, you do need information to put into those calculators, and a cumulative patient profile is often the best place to find that information. Like I said already, it saves you a ton of time if you're doing a pre-op or another referral letter to just attach a copy of your profile instead of having to dictate or type all the information into the forms. And then most profiles have a tab for allergies, and if that's not completed, then you won't get warnings when you try and prescribe a medication that a patient might have an interaction with. A good example is sulfa allergies. So if you plug sulfa allergies into your EMR, you might prescribe a drug and you're not even aware that it contains sulfa, but a pop-up will remind you that there's an interaction or an allergy. So lots of good reasons for having a cumulative patient profile. Another common error is not to have a proper medication list, because the disadvantage is that you either would not know what medications patients are on, or if there are interactions and you're trying to prescribe a new medication, the EMR will usually alert you to a possible interaction. It also minimizes prescription errors if you don't have to rewrite the prescription every time again. What we do see a lot in the EMR world is the thing about active and chronic medications or inactive medications. So often I would look at a patient's medication list and they were prescribed, doxycycline last year for acute exacerbation of COPD, but it's still showing on their active list. And usually what happens is when you attach a profile to a referral letter, all of these medications are listed, even though the patient might not be taking it anymore. So it's important to update your medication list with those that are active and not active anymore, or chronic or short-term, that sort of thing. So here's just a snapshot of our EMR for our test patient. And I don't know, I don't expect anyone to respond, but there is obviously a typical error on this medication list. And I'll, maybe if you're not used to mail access, usually the medication list, the dosage, quantity, and the start and end dates are in there. And the drugs are often listed as either continuous or short-term. And I know Akiro has a similar way of documenting it. So the error here is that the amoxicillin was a short course for probably 7 days, but was listed as continuous. So this medication will stay on this list forever and ever, unless someone changes it to short-term, in which case it will disappear after the 7 days. In Akiro, it's important to make sure that you inactivate medications when they're not important anymore. Next area of common errors are in the SOAP note. And so I think we all know the mantra that if it wasn't documented, it wasn't done. And the College of Physician Surgeons feels very strongly about this. You can argue until you're blue in the face that you always talk about smoking cessation with every patient that smokes. If you didn't document it, they will consider that you did not have that conversation. So it means that we need to document those lifestyle things, everything that we talk about with patients, because if you don't document it, it wasn't done. And the effect is that if anyone else sees a patient, then they wouldn't know if you've done it or not. You might think you do it with all your patients, but other people won't know that. So it is important to document everything that's important. The progression of the disease is often not monitoring. So I'll have a couple examples come up, but often I would see a note that just says hypertension and the prescription that was given. And I have no idea whether hypertension is stable, is it improving, is it deteriorating? And I think those sort of things are important to document. So the progression of the disease needs to be documented. The other thing that I see a lot with the EMR is that sometimes unnecessary information is documented, or in this case, duplicated. And a good example is most EMRs, if you renew a prescription, it documents the fact that you renewed it somewhere else in the EMR. But physicians still, in their plan, would type out renewed amitriptyline 10 milligrams at bedtime for 3 months. That is really unnecessary to type again because it is already documented somewhere else. If a patient had an ECG and it was scanned into the EMR, there's no need to retype the information that you got from the ECG report or X-ray report to summarize the report again, because the report is there for people to see. So often we see people error on the one side for not putting enough information in, but then on the other side, sort of wasting their own time by typing stuff in that's already documented somewhere in the EMR. So here's a prescription, and this is probably more a paper chart. So imagine the typing was a legible handwriting. So often I would see this in a chart: hypertension follow-up, blood pressure reading, and then prescription with a signature, and then either the doctor or the billing clerk afterwards look at it and put a billing code on there. And so this is a good example that we see a lot, where there's no SOAP note format, so we don't know actually what the patient is saying. Do they feel fine? Do they have headaches? Do they have side effects of their medication? Your assessment is not just a blood pressure. Sometimes on a regular basis, you want to see if there's any end organ damage from the hypertension. So you might want to check for things like that. And then if it's an EMR, you don't need to type out the medication because it is somewhere there. If it's a paper chart, then this would be fine to type like that. The reason I put the 5B on there is because if you ever get audited by MCIB, they will not accept this note because there are criteria for using the 5B code. And I'm not going to go into that, but I encourage you to maybe at some point go and read what are the criteria that needs to be documented to be able to bill a 5B. So if this doctor ever gets audited, this would not be acceptable to MCIB. Another common one that we see is depression and Ativan. And the one requirement that we insist on when we do PEP assessments is that there should be some sort of objective measurement of how the patient's depression is going, either by using a PHQ-9 form or some sort of tool that you can use. And the other requirement that we insist on is the documentation of suicidal or homicidal ideation. And some people argue with us and say we're not going to ask that every time. But if you ask a psychiatrist, they would say that you have to ask that at every visit. And so it's important to document the lack of or the presence of suicidal or homicidal ideation. And again, the 5B was built for this one, and it would not be acceptable to MCIB. So here's another prescription, and this is a diabetic patient who's being followed up, and there's maybe a little more information in here. So patient doing well, A1C is 7.7, there's a blood pressure and review meds, and this is an EMR that would be okay because the meds would be documented somewhere else. The doctor's signature, and then the fee codes for QIP for chronic disease management. So 64B for the chronic disease and 65B for the fact that it's a diabetic. So what is wrong with this picture? Not sure. Maybe I'll see if anyone can unmute and just speak up and tell me what's wrong with this. Okay. I'll just answer you. You cannot bill the 64B and the 65B if you did not use a flow sheet for managing the chronic disease. So apart from the fact that this is a better note, but still not a good note, it still is not in the format of a chronic disease flow sheet, and therefore you're not allowed to bill the QIP diagnostic codes for that, or billing codes. Billing errors, I'm not going to spend too much time in here. That could be a talk on its own. But every single code that's in the fee schedule has a requirement for what needs to be documented. A good example is the 3B, or the complete physical or periodic health exam. There has to be documentation of going through the patient's profiles, or family history, that sort of thing. That's one of the requirements, for instance. But there are many others. So it's important to look at the fee codes at some point again and see what needs to be documented, so that if you ever get audited, you're not in trouble for that. I do want to come back to template errors, because in my experience and some of the other assessors with the EMR, that's probably one of the other common errors that we see, is the abuse and misuse of template errors. And quite often it's because a template has been created for a sort of general scenario, and it's being applied to every patient without editing it for what happens or what is it unique about this patient. And I'll come back to, I think I have an example coming up in my next slide. The other thing also forms, if patient has a WCB or a disability, it is helpful if you can just sort of copy or print out the patient summary or profile. And that's another thing that we see quite often. So here's a good example of a template. And actually, this is one that I copied word for word from a recent consultation report that I got from a patient. Patient was seen for headache follow-up, and a bit of a story. And in the physical exam, mental status was normal, visual fields were full, and eye movements normal. The optic discs were normal, visual acuity was fine. I mean, the rest of the report. So on the sort of just looking at that, that's not too bad. So you might think, well, that's acceptable, except in this case, the patient only has one eye, and it's one of my patients. And so when I read that, I'm looking at it and I'm like, did you actually even examine the patient? Because you would have known that there's one eye. You can't say that eye movements were normal and visual fields were normal. So another example that I've seen recently is a template for someone with pelvic floor pain. And obviously the wrong gender template was applied to the patient. So this female patient now suddenly has problems with her prostate and needs work on that. So it's important to, when you use templates, to use the correct template. And also, if you are dealing with a female patient, that you shouldn't say the uterus was normal if the patient had a hysterectomy. So that's sort of kind of things that we're picking up with the template abuse or misuse. So that was a bit of a long didactic monologue, and I think hopefully I've covered some of the highlights, but I left enough time because I think there's more value in hearing if there are any questions from the audience. So currently you're all on mute, and if you have any questions, now is your time to speak up. And Andrew, sorry to put you on the spot, but do you know the latest number for EMR uptake in the province?
So as of 2019, it was 83%. I think this year it's gone up a percent or two. It's closer to 85.
85%. That's pretty good. Go ahead. I see a hand there. Your name is Economics Overflow, but I'm pretty sure you have a different name.
Hi, it's Victoria Ditkovska from Economics Department. I just had, thank you very much for the presentation. It's very interesting and helpful to understand certain details. I was just wondering if there are any tips or any observations you could make in terms of like using pandemic codes or maybe expecting to use virtual care codes?
So if I'm understanding your question correctly, you're talking about the 510A codes that we use for phone calls and video calls?
Right. Yeah, it's currently the 510A, code.
Yeah. And so, I mean, that's kind of our world right now. So and the clinic where I'm in use a lot of that. So as far as I know, and I could be wrong, so don't quote me on it, but as far as I know, you're allowed to use the code once a day with the patient. And if you do end up deciding to bring the patient twice a day, you're right, actually it is twice a day. So you can use it twice a day when you call a patient, but if you do bring the patient in for a physical exam following one of those calls, I think you're only allowed to use it once a day. And you are allowed to bill a 510A in the morning, for instance, and if you bring the patient in the afternoon for a physical exam, you can bill a 5B for that too. For the moment, both the phone calls and the video calls are the same code, so 510A. So there's no distinction between the two, but obviously in your documentation of it, you should distinguish between whether it was a phone call or a video call. Does that answer your question? I know we use a lot of that, and I know also with the new negotiations from the SMA, when the pandemic codes do not exist anymore, there will be a different version of the same code. So one of the good things that came out with the pandemic.
Yeah, thank you. I was wondering if there are any maybe parts of the examination that need to be like charted differently, or if like everything you explained today basically holds exactly for pandemic code.
So you're reminding me of something that I didn't mention, and there is something we document in our notes, and that's we do a quick check-in with the patient about confidentiality. And so we have a template for that with checkboxes to remind us of the questions we ask. So we ask questions, are you alone in the room? Is there anyone else that can hear you? Is there anyone else that can see you? And so we have a few questions like that, and then we have a question for ourselves at the end that we document whether we experience any privacy breaches during the call for whatever reason. So yes, we do document the things that we go over. We also, depending on what it is, if it's a video call, I would often just sort of turn my camera around in the room so that the patient can know that I'm the only one in the room, because we do have patients that think there might be a crowd sitting outside the view. And so I do that sometimes with some of my patients. Because we're in a clinic with lots of students, I often have students in the room, so I make sure that I identify them with the patient before I continue the call. So yes, so those things I do document about the privacy issues with video and phone calls.
Thank you very much.
Does anyone else have any questions? Didn't see anything come up in the chat.
Yeah, unfortunately, I don't see the chat box, so I'm relying on you to tell me.
I guess I'll just maybe ask another one. Is anything different when there's an uninsured service happening, or all these things are applicable?
So they're all the same, whether it's insured or uninsured services. So I might document maybe one extra line. So let me think of an example. If I'm doing cryotherapy for wards, which are not insured services, and I bill the patient extra for it, I might say something about it, that these are wards and the patient was made aware of the fact that it's uninsured. Or if I'm removing a lesion for cosmetic reasons, I might document that I informed the patient that it is for cosmetic reasons and that it's not insurance service.
Thank you.
Just pause a moment here if anyone else has any more questions.
One of the things that I'm just reminded by that question that we also document is if we obtain consent for procedures, and I didn't talk about that in my slides, but we have a checkbox on our procedure template that consent was obtained, and usually we scan a copy of the consent form into the EMR anyway.
Oh, go ahead.
Sorry, who goes now?
Sorry?
Can I ask another question?
Yeah, go ahead.
Sorry, there is an echo. Maybe Andrew could mute Dr. Miller, maybe could be muted for a sec. Oh, no, it's good now. Sorry, my other question was, oh gosh, while I was speaking. Okay, I'll let Navid ask his question and I will try to recall mine. Sorry.
Sure. Thanks, Victor. So what I would like to know, like, is the note taking, like, how do you take notes when you speak with an allied health professional? Like, for example, you have to do a triage, you're speaking with a nurse who is seeking advice. So like, in those circumstances, like, do you have to keep anything special in mind, like for the purpose of billing or something else?
Sorry, I muted you there, Dr. Mueller. I think you're still on mute, Dr. Mueller.
Okay, sorry, there we go. So I'm not sure if I understand the question correctly. So if I'm speaking to a nurse at the emergency department about sending a patient, is that what you're sort of talking about?
It does not have to be necessarily in that manner. Like, for example, a nurse calls you from a nursing home and requests you for some advice regarding a patient.
Yeah. Okay. I get your question. So when those would fall under the category of telephone calls that I get frequently, and I'll get them every day from a nurse or from a physiotherapist or whoever, or pharmacist even, about a prescription. So those are what I categorize as telephone calls, and all of those should be documented. And again, thanks for reminding me. It's one of the things we see quite often, that those calls are not often documented in the chart. And so in the EMR, there are categories for some of those things. So we have a category for telephone calls from an allied health professional. And so we just open that task in the Med Access, and then we document whatever is important from that conversation. So often I would document that pharmacist phoned me about whatever, testosterone injection is unavailable right now, and then I would document suggested using whatever, the gel or whatever. So that would be a quick documentation of my phone call. Also phone calls to the patients. Before we were able to bill for the phone calls, people were not very eager to document their phone calls because, first of all, it's a lot of work, and second of all, they don't get paid for it. So they thought, well, then I'm not going to document it. But it is important to document all those conversations that you have with your patients or with anyone else about their care.
Yeah, thank you.
Yeah. And we didn't get any questions about speech recognition software, but I'm a big fan of those, and there are many different vendors out there. We now in the health region, or health authority has Fluency Direct, and if you haven't experienced that, and I have to say I don't have any shares in the company, but I think it's the best thing after sliced bread because it made my life so much better. I can see that my quality of my documentation has improved because I'm not afraid of typing too much. I can just speak what I need to speak into. So, and I don't know, Andrew, if you guys are involved with Fluency, but if you need more information about that, definitely reach out.
Yeah, we're very involved in Fluency because there's a lot of information available on our website, and but actually next month's webinar session is about that specifically. It's about using Fluency Direct.
Okay, I'll make sure that I'll attend that one because it's very good and very helpful, and I can always learn more. But it definitely helped improve the quality of records.
If there's no other questions, maybe. Oh, Victoria.
Hi. So my question is, I guess this is sort of reminds me of online billing course, and I'm just wondering if you saw that course, Dr. Miller, if you think there should be something that should be improved. I know they've updated the course like about a year or so ago. I don't know if you've seen the most recent version. I'm sure there is, there are a lot of physicians that still need the information that you presented today, and I'm just wondering if you saw the billing course, the most recent one, if you would be willing to submit some sort of recommendation for improvements to the ministry that we could maybe share with them, or if you have contact with them, you could.
So I can tell you that I have not seen the recent billing course. I haven't done a billing course for years, so I'm not involved in that part of things. But what I can tell you is that I know for a fact that doctors underbill by about 20%. That was a study that was done not that long ago. But then in the same breath, sometimes they also bill incorrectly for things that wasn't or shouldn't have been billed for. So I think what we did sort of a bit of a mini project with our residents once and advised them to go and page through the fee schedule on a weekend and see if there are any surprises. And they all came back on Monday and said, oh, I didn't know I could bill for this or that or these or I didn't know I had to document this or that if I want to bill a 3B kind of thing. So it's probably worth your time at some point to just page through the fee schedule again and pick up some of the things that I think you'll be surprised about that maybe you're doing, but you're just not billing for it or you're billing incorrectly for it. But sorry, I haven't looked at the billing course itself recently, so.
Thank you.
If there's no more questions, maybe we can wrap this up then. Thanks very much, Dr. Miller, for this presentation. I think it was really helpful. And we're going to repeat it tomorrow, as I mentioned at the beginning. And I think that's it for today, if there are no further questions.
Oh, thank you very much for everyone for your attention, and you can always email me. Most people would know how to get hold of me if you have questions afterwards.
Thanks very much.